Welcome back to Primary Focus. I'm Dr. Tara Kiran. In our last episode, I introduced you to one of the primary care teams I met on my trip to the Netherlands. This episode is a part 2, so if you missed part 1, now's a great time to hop back one episode and catch up. And if you'd like to read and see more about my trip to the Netherlands, I've posted some of my reflections and some of my photos of my trip at primaryfocus.substack.com. And if you're all caught up, well, then let's just dive back in.
Ja, het is het makkelijkst. Zoals ik 's ochtends met zo'n envelop van zo, er staat niks op.
Remember Dr. Suzanne Ligthart? She's one of the practice owners who gave me a tour when I first arrived at the Nijmegen clinic. She had a really busy day when I was visiting, but I got to shadow her during some of her patient appointments in the afternoon. The appointments were reminiscent of patient visits in Canada, but between appointments, Suzanne shared a lot about what she loves about being a GP in the Netherlands and where she sees some of the challenges. At one point, Suzanne tells me she wants to show me something, and she pulls out this beautiful dark leather doctor's bag.
This was really personalized.
Oh yeah, so everybody has like a standard doctor bag. She and her colleagues all have similar doctor bags made by a local woman who specializes in the craft.
Who are really good
at making these doctor bags, yeah. And what's in it then? Usually like your stethoscope and you've got lots of things in it.
Blood pressure, temperature, also for...
Inside, the doctor bag is fully stocked with everything she needs for a home visit. A blood pressure monitor, thermometer, Ventolin, nose sprays, urine tests.
Glucagon.
What's that?
Glucagon.
Oh yeah, glucagon.
Yeah, glucagon. Yeah.
If you're a doctor or even a patient, you'll know that in Canada, you don't often run into a doctor's bag. I mean, most of us practice out of clinics almost all of the time, and our office exam rooms have the tools we need. But for GPs in the Netherlands, they're also on the road. Every day from 1 to 2 p.m., all GPs but one in the practice have their schedule blocked off for home visits. Home visits are a routine part of practice. And this was true not just in Tim and Suzanne's practice in Nijmegen, but also in the practice I visited in Amsterdam. Each GP has their own doctor's bag that they take with them on home visits. Suzanne's bag is full of equipment, including common medications given intramuscularly.
Midazolam, morphine, adrenaline.
Wow, you've got really. Have you had to use those in the people's homes?
Yeah, sometimes. Yeah, especially when
like if they're having
end-of-life care. Oh, yeah.
GPs here commonly support end-of-life care with home visits. And before you ask how they can offer this care when they only have 1 hour blocked off for it, remember, patients are supposed to live within a 15-minute drive of their GP's office. And usually it's even closer. I mean, Tim talked about how he commonly rides his bike for these home visits. Fittingly, the Dutch word for GP is huisarts, which literally translates to house doctor.
Whoa,
so you guys are called house doctor and you do home visits.
And we do home visits, yeah. But not so
good.
Yeah.
Not as many doctors do home visits in Canada. Is it pretty standard for a GP to do home visits here? Yeah. Every GP does it. Yeah. Suzanne says that since the COVID-19 pandemic, they've been doing fewer home visits. But it's obvious to me that these in-person home visits mean a lot to Suzanne. And you can tell that she feels a personal responsibility to care for her patients through to the end of their life. As we chatted, she picked up a card from her desk. It has a picture of an older gentleman on it.
So he passed away.
Is that your dad? Or?
No. It was one of the patients, but they said always the card. Oh. And I think it's also so touching that they...
Because you saw him a lot at home.
Yeah. He wanted to stay at home. He lives across the street. There's a park where the people live in.
A trailer park, I think, is maybe
like a trailer park. Yeah, it's camping. So special people live there, and they live there fixed, no holiday, but just whole year around.
So he was living at the trailer park near
So he was living,
and he wanted to pass away.
And he wanted to pass away in his home.
Yeah, in his home.
But we didn't manage to do it because home care was not available, and we are not used to this because it was
the pandemic.
Yeah, no, this was actually 1 week ago. He passed away. But it's now, we have the shortage of doctors, but also nurses, like home care nurses.
So they weren't available
we were really also sitting together like, oh, what's happening? Because we are not used to this. Usually if we have...
Suzanne explained that palliative care patients, they require intensive nursing and home support in addition to a doctor's expertise. And in this case, there was a shortage of home care nurses. And so the patient wasn't able to receive palliative care at the home, despite the fact that she was personally able to support it as a doctor. She says that's the first time that she'd seen that happen. And she says even just last week, a colleague of hers had patients that were not able to get the home care they needed because of nursing shortages. And with this patient, who she has a photo of on her desk, the shortage of home care meant that they had to send him to a hospice.
Yeah, so it's a trend, and it really worries me. He should have been able to die at home. And it was okay now in the hospice. For his children, it was okay. But still, I think, this is not a good thing. But
it means a lot to them that you took care of them, I'm sure, because you've known him for a long time, I'm guessing.
Yeah.
Things aren't perfect in the Netherlands. Like us, they're facing an aging population and workforce challenges. And as we heard, GPs are becoming less interested in running a practice, and new graduates, they increasingly want to work part-time. But there are also big differences between how GPs operate between our two countries. I mean, almost everyone has a GP in the Netherlands. There's same-day care for urgent issues, and that's routine. They have efficient information systems. Patients can easily access their own records on an app. And GPs regularly do home visits. And it's not just this clinic. At the other GP practice I visited in Amsterdam, while the culture in the city was different than it was here in Nijmegen, I still observed many of the same things. The infrastructure and the context was maybe different, but the approach to organizing care, the types of other health professionals they've integrated and how they've integrated, all of that was actually pretty standard. Above all, I think what the Netherlands does so much better than we do is they delegate. There's a team in place, and each team member has a specific job. And there's a system in place to funnel patients to the right kind of care they need by the right person at the right time. How they do it is something I've been holding back on until now. It's the secret sauce of the Dutch primary care system. And to bring you to that secret sauce, we're going to jump back into my tour with Tim.
Well, here is some room for administration, so our practice manager is always sitting here. So this is the back office where the practice nurses sit and take all the phone calls and do the triage.
The practice assistants?
Hey.
Great job.
Yeah, the practice assistants, yeah.
Okay, are they nurses? They're not nurses, you said?
No, they are not nurses, but they are almost nurses.
Okay, but these are the 3 practice assistants?
Yes.
Plus you have 2 downstairs as well. So
Yes.
are there 5 in total?
Depends on the day, so on Monday morning.
Tim's talking about practice assistants. Not the same thing as a physician assistant, the kind of professional group we have here in Canada. To me, practice assistants, they seem to perform duties somewhere between a medical office assistant and a nurse. It's a pretty unique role that I actually haven't seen in Canada. These team members are the first line of contact for patients seeking care. And they happen to be the key to explaining why GPs in the Netherlands can look after so many patients and still provide timely care. Okay, to remind you, these practice assistants are the people who answer the phone. They triage the people who call in, and they direct patients into a few different streams of care. As you can imagine, they are among the busiest people in the office. But between calls, I did get a chance to ask them a few questions.
Can you tell me what your name is?
Yes, Kris Arts.
And what is your role?
Oh, I don't know the word in English. It's a doctor assistant.
You can say it in
Doktersassistente.
Okay,
Yeah.
perfect.
After 4 minutes, I have to call my next patient. But
In Tim's practice, there were about 6 practice assistants working on the Monday. 4 were answering the phone in the morning, upstairs in a shared workspace, and each had their own desk with a computer and a headset. One was at the front desk, and another was doing consultations. By 4 p.m., those on the phone had fielded about 220 calls, resolving many of the issues.
Like
Who
I'm gonna
have you been
call?
talking to today? What are some of the people that called in today that you spoke to?
There are people asking advice for fever and colds, and they asking what I have to do, how long is it take, what can I do, do I have to see the doctor or not? And then I say,
Practice assistants, they play a huge role triaging the patients who call in. They resolve issues that don't need to be seen by a GP. And they're trained to be able to ask appropriate questions for a number of the common reasons that patients call in. And then they can also provide related advice for things that don't need to be seen by a doctor. For example, they might counsel a parent who's calling about a child who's had maybe a fever for just a day or two. And, based on their call, they'll ask a few questions and they'll figure out, does this child have any red flags that really, might be worrisome and mean that they need to be seen by a doctor? If not, they can give parents the advice around the kind of supportive treatment that parents can give at home and when it is that they might need to call the doctor's office again.
So
most of the time for something like a cold, you're able to counsel patients and reassure them, and then they don't need to come in?
No. So they call us, and we think, hey, is it something bad? Has to see he see the doctor?
If it's not too serious. It
Yeah,
sounds
or
like.
not pneumonia.
Pneumonia?
Yeah, exactly. When I think, it's not, we give advice.
But practice assistants do more than just counsel patients on the phone. They resolve administrative tasks like, if a referral needs to go to a different place, they'll just go ahead and redirect that referral. They might also suggest prescription renewals. So those renewals requests will come in, they'll review them, they'll kind of tee it all up to be renewed, and the doctor then just needs to approve things with a click. If a patient has an urgent issue, they'll book a same-day appointment with the doctor, but they're also well trained to know what things can maybe wait a day or a week. And if they're unsure on how to respond to a phone call, they'll consult the physician, often by scheduling time to talk when the physician has a break in their schedule. They would then call the patient back themselves, though, and provide the counsel. They also see patients one-on-one in the office. It's what they refer to as consultations.
It's very diverse. It's every day a different day, and my job is speak with people on the phone, but my job is also see people on my own.
And what are the kinds of things you do in consultation? So
I take care of wounds, or I remove the stitches, or I remove a Mirena spiral.
You can remove an IUD.
Yes, we do it. The doctor will place it, but we can remove it.
Practice assistants can do many things independently in their consultations. They can give vaccinations, they can do pap tests, syringe ears, support wound care, take blood pressure measurements, and more.
Different. We are the right hand from the doctor, so we pick little things that we can do.
What would you say is one of the more challenging parts of your job?
Some conversations with people when they are really worried about some people are very, very aggressive. That's hard. We have also conversations with people are suicidal.
It's hard.
Yeah, that's a hard conversation. One time the spoedline, the emergency line rings, and so I pick up. And there was a woman stood on the high bridge, and I hear the wind to the phone. And they said, I want to talk with the doctor, so I want to thank her. And then I think, what I have to do now? I have to call ambulance. I don't want to hang up, but I don't know what to do. So then you have to think real fast.
What did you do?
I asked my colleague in the back office, go to doctor. And the doctor came to me, and she took the line, and everything was happening from call the police and everything.
So you were able to...
Yeah. Everything actually, was good. But it happens a lot of times, so yeah.
They have a tough job. They're the front door, and even in Canada, any physician will tell you that the job of the person answering the clinic phone is really hard. They need to figure out how to help the patient, and patients may often be in distress or angry and upset. What impressed me about the practice assistants in the Netherlands is that they seemed very well trained for this tough role. What kind of training do they have? You can become a practice assistant with 3 years of training right out of high school. The training is very thorough and practical and very contextual to the primary care setting. There's lots of role play in the classroom, and then they also spend some time in clinic. They're trained to ask patients appropriate questions based on what the patients are calling in about, so that they can triage them effectively. They triage them based on algorithms. These algorithms are actually even just available on a website, and I was told that they were developed in partnership with the Dutch College of GPs. So GPs, as a profession, have had input into how these practice assistants are trained so that they have confidence in the way that practice assistants are able to ask patients the right questions and then counsel them and decide on what the next step should be. Should they be seen in person? And if so, how long can they wait? And who can see them? It is striking that their role is so specific to primary care, so it's not like they're trained as practice assistants and then can go work in a different setting. The triage algorithms that they learn about are really specifically designed to reflect what it is that a general practice might see on a day-to-day basis. What was also interesting to me was that in addition to training on the clinical stuff, they spent a lot of time learning communication skills. For example, how to build trust, respond when a patient gets angry.
Got trained for how to communicate, because when you gonna ask the doctor about something that you don't know, and you come back to the patient and you say, I think it's gotta be, no, don't say I think, because the patient's gonna think, why you think? Ask the doctor why. So
they'll be anxious. Yeah.
So how can you talk to them so they got not anxious? So don't say the word but, because you did a really good job, but you have to know that. No, because when you say but, then you make the line that you say
before,
not strong anymore.
Absolutely, that makes sense.
Yeah. So it's know how to communicate to people so they don't interrupt you or don't make more worries.
Being a good doctor too is also about learning to communicate well with patients, and so we do go to school for that. And so it makes sense if you're on the front line and you're the doctor's assistant that you also have that training and are able to de-escalate and connect with people and also help them to feel reassured when they don't meet the doctor. That's what it sounds like you're trying to do. Okay, well, this has been really educational for me. I really learned a lot because we don't have doctor's assistants.
Oh, yeah.
And I think that's one of the big differences. In Canada, one of the big problems is that patients often have a hard time getting a timely appointment. So even if they have something urgent, it's really hard for them to get an appointment in a timely way. And then they have, nowhere to go. And so it's very challenging. But here it sounds like most doctors' offices accommodate urgent issues on the same day. And I think part of the reason sounds like it's the doctor's assistants are triaging the phone calls.
We split. Oh, you can come. You don't have come. Oh, you can come tomorrow. Oh, you can come now or no. So we filter everything before it's going to the doctor.
And what do you do if the doctor's schedule is full, for example?
It happens a lot of time. This week the doctor is fully booked, but we know when something is urgent. So when something is urgent, I say to the doctor, this woman has to come here. Be seen. It's my job to know. And so the doctor is looking to the agenda to where maybe on a phone or a block from administration. So they can come today on the practice. So the doctor listen to us, and it's nice. So they take us serious as doctor assistants. status. We always can ask the doctor for advice, so I think he has to come, but not really today, but the first appointment is next week. It's too long, what do you think? So the doctor will look with us in the agenda.
You're working as a team. So.
Yeah, we work as a team, and that's very important.
And they stand up for you.
Yeah.
Okay, thank you. I know you have to go back to your job.
The role of the practice assistant to me is one of my many takeaways from my visit to the Dutch health system. It's a role we can easily adapt here, and I think one of the key reasons GPs in the Netherlands can look after large numbers of patients and still provide timely care. I love that practice assistants are trained in primary care triage and communication, and that the algorithms they use come from the Dutch College of GPs. Their training is standard and only 3 years, which actually means it's a workforce we can easily train up, far faster than the minimum 9 years it takes to be a fully licensed family doctor in Canada. It's great that practice assistants are also empowered to resolve issues on their own and that they have the skills needed to manage demand that comes through the front door, figuring out if, where, and when patients need to be seen and by who. I mean, in Canada, we talk a lot about patients being seen in the right place, by the right person at the right time. Everyone agrees that's the goal, but it's a real struggle to make this a reality. But the practice assistants, they make this happen in the Netherlands. They also take work away from family doctors and nurses, for example, by doing pap tests and immunizations. That frees up doctor and nurse time to focus on more complex issues. Now, I've mentioned the Dutch College of GPs more than once. They produce guidelines for GPs by GPs. To me, they form the backbone of a lot of what's working in the practice setting. These guidelines, they're embedded in the electronic medical record, for example, in the prescription module that Tim showed me, also in the checklists that the nurses like Mariana were using to follow patients with stable chronic conditions like diabetes. It was really great to see nurses work autonomously in managing stable chronic conditions, using these guidelines as a basis and consulting GPs when needed. There was also clearly a very high degree of trust between GPs and nurses and their practice assistants. In Canada, stable chronic conditions like diabetes and high blood pressure, they're largely managed by family doctors. Some family doctors do work together with nurses, but in many of the settings when family doctors and nurses work together, the doctors and nurses often see the patients in the same visit. So a nurse might start the visit, for example, and do some aspects of care, maybe take the blood pressure, the weight, document a few things about a patient's lifestyle or habits. And then the doctor takes over and does the rest and maybe then, tries to counsel the patient on kind of what needs to be done differently and prescribes medication. But often this type of setup results in duplicative care with the time of both professionals being used instead of just one professional seeing the patient. Patients are no doubt getting great care, but in a system that's strained with not enough doctors and nurses to go around and 6.5 million people who don't have primary care, it makes sense for doctors to delegate some of the more routine aspects of care to our skilled, well-trained nurses. I was also struck by how efficient Tim's practice was. Prescription renewals were quick, just 1 to 2 clicks, not so many the way that my practice is. And it was great to have these prescription renewals integrated with decision support, so you didn't have that cognitive load of trying to figure out what the right prescription was to pick. Making referrals was pretty easy too. Most tests and specialists are actually managed through hospitals, and there seemed to be one standard referral portal for all hospitals in the country. Contrast that to most jurisdictions in Canada where there are umpteen different referral forms and no central portal for submitting these referrals. I mean, referrals have become a huge headache for family doctors to manage in Canada. I also noticed that doctors in the Netherlands didn't seem to write long notes, and I wondered if that was because there were less medical legal worries in general in the Netherlands. Tim and Suzanne's practice had just started using e-consultations a couple of years before I visited, and they'd already started to see some of the efficiencies. Patients could submit their questions through an app and book appointments through that same app, and the app was seamlessly integrated into the doctor's chart. I did learn that not all GPs in the Netherlands were this far ahead with integrating the technology though, so I do need to be careful not to generalize this to everybody. One of the most striking things to me was what GPs in the Netherlands did not do. As we talked about, they don't do much stable chronic condition management. That's done by nurses. But they also do very little preventive care. That's not because people don't get preventive care in the Netherlands, it's just that they get it elsewhere. Pap tests are done by practice assistants. That's how we screen for cervical cancer. Colorectal and breast cancer screening, though, are actually handled by a national agency. Family doctors have nothing to do with it. Well, baby checks and immunizations, they're handled by a totally different type of clinic. And in general, patients are not booked for preventive health checkups. That's just not a thing in the Netherlands. They don't think that it's really a cost-effective way for them to use their time. In contrast, family doctors in Canada spend a lot of time on preventive care, on counseling patients around cancer screening, doing well baby checks, providing immunizations, and doing preventive care visits where, the expectation is for us to use guidelines and counsel people on a whole variety of things. It made me wonder, how much family doctor time could we free up if we took that work away, gave it to someone else? Could be other people in the clinic, could be another agency, could be through health promotion campaigns where we educate the public about how it is that they can have a healthy lifestyle. But what if we freed up that physician time? What could that mean for all those people who are struggling to access primary care in Canada? Doctors could use their very advanced skills, training, and experience to assess and manage the hardest stuff in primary care. Those patients with new problems, things that are urgent, and patients with complex medical issues or social issues that interplay with the medical issues. Unfortunately, right now in Canada, there are so many people who have acute and complex medical issues and have nowhere to turn for ongoing care. The other striking thing in the Netherlands was just the ethos of GPs around access. I mean, it's just ingrained that they need to provide patients with timely access. And it's tradition that GPs are responsible for their patients 24/7. Yes, 24 hours, 7 days a week. Now that sounds pretty onerous, but the Dutch have figured it out. They have what I think is one of the best after-hours care systems in the world. When your GP office closes at 5 p.m., it's still easy to get care. More on that at our next episode.
Hey, Tim, so as we're driving over to this out-of-hours place,
Yes.
so it's the out-of-hours center. It's basically a cooperative of the GPs that are in the area, and it collectively serves about 400,000 people.
Yeah, patients, yeah.
400,000 or
Yes.
40,000?
No, 400,000, yeah.
Patients, well.
I hope you'll join us next time as we dive into the Dutch system for after-hours care. We're going to take a quick break and we'll be back with that episode in 2 weeks' time. And then we'll end off this 4-part series with a conversation with Rosemary Hannum, who was actually on the trip with me. We'll talk about how Dutch doctors are held accountable for providing timely care to the patients they serve, and we'll also discuss our key takeaways and reflections for the Canadian system. Primary Focus was created by me, Dr. Tara Kiran. Mariam Dinesh supports research and fact-checking. Seema Marwaha and Emily Holton are storytelling and media advisors. Our producer is Avery Moore-Kloss. A big thank you to Rosemary Hannum for her help with this episode. And huge thanks to the many Dutch people who took time out of their day to tell me about their primary care system. I talked to so many that I didn't feature in this episode, but really who informed my knowledge about the system and whose comments and thoughts are reflected today. So thank you to them. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on how the Our Care Standard could help us solve the primary care crisis, visit ourcare.ca. Primary Focus is supported by a grant from the St. Michael's Foundation, and I'm supported as the Fidani Chair in Improvement and Innovation at the University of Toronto and as a scientist by the Departments of Family and Community Medicine at St. Michael's Hospital and the University of Toronto. Is there more? Oh, I'm Dr. Tara Kiran. Hey, it's Tara again. Something you hear me talk a lot about on this podcast is the Our Care Standard, a clear outline of what every person in Canada should be able to expect from the primary care system. The standard was actually shaped by feedback we received from nearly 10,000 people in Canada back in 2022-23. And now we've just launched another survey and we want to hear from you. Whether you have a family doctor or not, we want to know, how does your healthcare stack up to the Our Care standard? It only takes 10 to 15 minutes to share your story. It's completely confidential, and it'll help researchers like me understand what's needed for a stronger, more equitable healthcare system in Canada. And more importantly, it will help us all hold our governments to account to deliver the system we all want and deserve. You can take the survey anytime between now and July 9th. Just head to ourcare.ca/survey or click the link in the show notes of this episode. The Our Care survey is a research study led by me, Dr. Tara Kiran, at the MAP Centre for Urban Health Solutions at St. Michael's Hospital in partnership with the Canadian Medical Association. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.